So mine is case number 2. So this is a child after transplantation, but it's a very small child, only 5 months old. So these are data at admission to the HSCT department. Boy, 5 months old. Diagnosis is primary immune deficiency, severe combined immune deficiency. Concomitant conditions since birth are chronic bronchitis of the viral origin and severe enterocolitis, atopic dermatitis. So as for the intestine problems, such as enterocolitis and atopic dermatitis, so they necessitated nutrition of this child with oligomeric formula. 2 weeks before admitted to transplantation department, so you can see the formula which was given to the child, Peros oligomeric amino acid-based formula, and 2 weeks prior to transplantation, partially parenteral support was started at the moment of admission to transplantation department. Before the conditioning, the child had his parameters are shown here. Practically, the patient is in a very severe malnutrition status and chronic one. And as for the transplantation with hematopoietic stem cells, so it is described in this slide. You can see the conditioning regimen, and the transplantation is done from haploidentical donor. And then neutrophils on day 9 and platelets on day 17. So in this slide, you can see the curve of weight change. So you can see weight in kilos, and here you can see days with regard to transplantation. This is day 0, that's the day of transplantation, and this stands for disorders of intestine and lesions of intestine. These are some other problems, and also kind of feeding, that is Peros, using tube. On day 54, gastrostoma and parenteral nutrition. And so here we can say in brief, as I have mentioned, the child was admitted partially, or while already partially on Peros and parenteral. After conditioning, the child lost the appetites, and you see that he ate much less. So the volume of parenteral 3-component nutrition was increased. According to calorie content, it was quite low. And, together with the problems that he already had, such as the GI lesions, severe enterocolitis, and so on and so forth, he started losing his weight. And he had hyperbilirubinemia and hyper-3-glycerinemia. So you can see that because of that, the fatty emulsions were interrupted, and the volume of energy that he was given went down. In a very short period of time, he lost 1 kilo with his total weight of 6 kilos. So the nutritionist was invited, and the nasogastral tube was, positioned, and trophic nutrition was started in very low volume because the child could not withstand and hold larger amounts. So this was then replaced by parenteral nutrition. So you can see that the volume of the parenteral nutrition went down. The enteral nutrition was increased based on the tolerance of the child to this enteral nutrition. And finally, the level of 540 kilocalories a day, and the parenteral nutrition was even interrupted, but complications of post-transplantation complications, such as enterocolitis and the respiration problems and vomiting, became more frequent, and because of that, the enteral nutrition had to be reduced in volume because the child could not absorb more. So we returned to the parenteral nutrition. And you can see from this weight curve, we have managed to correct the nutritive status. And despite the fact that here we again saw problems in this child, but he started gaining weight slowly, step by step. And at the moment when I was preparing for this presentation, on day 70 after transplantation, the boy has intestine problems, so it's because of the hypofunction of the graft at the same time, and he also has the respiratory viral infection and the nutrition which is given. So it's described here. At the moment, it is a little bit modified because, by the way, I should mention the child is 5.8 kilos. He's almost 6 kilos by now, so he still gains weight. And so he still has aversion for food. So peros we cannot feed him, but through the gastrostome, so we see that the child has to be fed with either tube or gastrostoma. He won't be able to be fed through, peros. And so the oligomeric formula is used, and the volume is increased. And at present, enteral nutrition is a little bit exceeding in volume that of parenteral. And so we should say that we have managed to maintain his nutrition status, so it improves. This is what I wanted to show you. Thank you.
Thank you very much for very interesting talks you gave to us. And I have two questions. First question is, would you recommend any vitamins or any other supplements in case when the patient receives home nutrition or sipping, so we couldn't control the quality of the food, and we're not sure that there are enough vitamins and micronutrients, or maybe fish oil or calcium in patients who receive steroids? That is the first question. And the second question, do you use in your practice any drugs which stimulate appetite, but not antiemetic drugs, but for stimulating appetite for patients who have anorexia, have no appetite, but no vomiting and nausea? Thank you.
Okay. So for supplements, if you're using a homemade formulation, it's really important to have somebody calculate the nutrients, because you very well may need to supplement with a multivitamin or some specific nutrient that's very likely deficient. Because you're not using a formula that's been developed in a lab, you're likely going to get deficiencies. So yes, and that's pretty easy to identify, because you can just develop the formula ahead of time and then, identify what needs to be supplemented throughout the course. In terms of your second question, would you mind repeating it again? And just in terms?
I mean, there are some drugs and medicaments who could increase anorexia, but I mean not antiemetic drugs. So there are some drugs which are used in psychiatry, for example, in patients with anorexia, or some other drugs which could use to stimulate the appetite. Do you use it in pediatric practice in your clinics? Or?
Yeah. So just I can speak for our institution. We don't use appetite stimulants that often because we don't use Megace at all. And Periactin, we don't have good results with. And when you look at the data, actually, essential fatty acids have have better, or I would say equal outcomes in terms of their effect on appetite compared to periactin or cyproheptadine. And that's all we kind of use, but you had some other comments.
No, I will just endorse Elena that we do not promote using appetite stimulants because there is no published evidence for its benefit. There are randomized trials with cyproheptadine. There are trials with megestrol acetate. We just talked about that. There are no studies with dronabinol, which is one of the drugs used, psychoactive drugs. None of these have been shown in these randomized trials to be beneficial as well as safe. Cyproheptadine has not been found to be beneficial compared to the placebos, and while in meta-analysis, while in megestrol acetate, it did improve weight, but mostly water and fat, which is what I shared. So I don't think it's worth working on a peptide stimulant, which is not going to give you any lean mass gain, which is the most important thing we are looking at. Other agents, since we don't have adequate evidence in children, we would stay away from them. What we usually do is, if they have appetite loss, to monitor, and if they are losing weight, to start them proactively on enteral nutrition rather than working on appetite. Many children have gastroparesis. So although not really antiemetics, but we use prokinetics in them, and that really helps. So any comments on the two case presentations from any of the attendees? I have one comment for a colleague who talked about that very interesting transplant child who had SCID. The comment which I had was, this child had severe acute malnutrition even before the child went into transplant, and I think it was an elective transplant because you could have waited. So usually most centers would practice proactive nutrition with a tube feeding upfront, build up their nutritional status and get into transplant rather than going into transplant with a SAM, severe acute malnutrition status, which puts them at risk of higher mortality. So do you have any comments, and what did you have any reason to take them with SAM into transplant?
Thanks a lot for your question. We, of course, understand that children who are being prepared for transplantation, we should offer the correction of malnutrition. It should be a part of the preparation process for transplantation. So far, if I can put it this way, we are studying this possibility, and we are conducting a trial, but our dietitians cannot actually capture all the patients who are admitted, including for transplantation as well. But once the algorithms are drawn for transplantation patients, that is, when the physician sees the patient, he should know what kind of parameters are to be taken into account or considered, and what kind of preliminary nutritional support should be offered.
So do we have any further questions on any of the cases? I think they were excellent cases demonstrating the impact of timely intervention with the combination of enteral and parental nutrition used in tandem to optimize the nutritional and transplant outcomes, and they were really impressive. So thank you for sharing those experiences with us. So we've reached the end of this 5th International SIOP workshop, and I might request my co-chair to give the closing remarks.
So again, I think we'd all like to thank you on behalf of the SIOP PODC Nutrition Committee for attending this conference. I think we all hope that it was beneficial, particularly in just improving your awareness of the research that is available, both in high-income and low-income countries. I think what became evident to me in listening to all of these wonderful presentations from Russia was that you really have a lot of data here that you can work with, either institutionally and collaboratively. So I would certainly encourage all of you to kind of build upon those relationships and create some data within Russia, because it was nice to see all of the advanced nutritional anthropometrics that each and every one of you presented. Certainly if the SIOP PODC can be of any support or help to you, please contact Dr. Aurora or myself. And if there's no other further questions, we can close the session.